এখন স্যার হচ্ছে আপনি ওই যে নিচে যে জুমের যে অপশনটা আছে, আপনি লাইভে অটোমেটিকলি এখন চলে আসছেন। আপনি স্যার হচ্ছে ভিডিওটা অন করে তারপর হচ্ছে স্যার আপনি ওই যে নিচে যে টুল বক্সটা আছে জুমের, ওইটা স্যার একটু ক্লিক করে শেয়ার স্ক্রিন দিয়ে আপনি স্যার সাইট ওপেন করেন।
একটা মিনিট, একটা ফোন কল রিসিভ করে নেই। হ্যালো হ্যালো, ওয়ালাইকুম আসসালাম, কে বলছেন? অমিত, আমি একটা অনলাইন লাইভ ক্লাসে আছি, তো আমি পরে কথা বলবো, আপনি আমাকে পরে কথা শুনতে দিচ্ছি। ধন্যবাদ ধন্যবাদ, সরি। হ্যাঁ, আচ্ছা, এখন কি আসছে? এখন তো
এখন হচ্ছে আপনি এই যে নিচে যে টুল হচ্ছে স্যার জুমে চলে যান।
আমি আবার জুমে চলে যাব। ইয়েস,
জি জি স্যার, জুমে
আমি
যে
জুমে গিয়ে,
স্যার শেয়ার
জুমে
স্ক্রিন
গেলাম।
দিয়ে
হ্যাঁ, জুমে
এখন
গিয়ে
স্যার
এখন
হচ্ছে
শেয়ার স্ক্রিনে যাব, শেয়ার স্ক্রিনে যাব।
জি জি স্যার শেয়ার স্ক্রিন যান।
চলে গেলাম। আচ্ছা, হার্ট ফেলিউর, শেয়ার,
স্যার আপনি
ফুল স্ক্রিন।
ভিডিওটা অন করে দেন, তাহলে হচ্ছে স্যার দেখা
হ্যাঁ,
যাবে।
ফুল স্ক্রিন চলে গেলাম। আচ্ছা, আমার চেহারা তো দেখা যাচ্ছে না।
না
হ্যালো,
না স্যার, না স্যার দেখা যাচ্ছে না।
যাচ্ছে?
না স্যার দেখা যাচ্ছে না।
এটা কি করব, দাঁড়ান, এটা আবার জুমে ব্যাক করব?
না না না, আপনি স্যার ওই যে ভিডিওটা অন করে দেন, আপনার এখানে অপশন আছে না
আচ্ছা,
ভিডিও।
হ্যাঁ, আমি দেখছি স্টার্ট ভিডিও, এই যে।
জি জি স্যার।
ওকে,
আপনি অলরেডি লাইভে চলে আসছেন, আমি আপনার মেসেঞ্জারে লিংকটা দিয়ে দিচ্ছি।
হ্যাঁ, দাঁড়ান, আগে আমি এইদিকে সাইজ করি। স্টার্ট ভিডিও তো দিলাম, আবার কি হয়ে গেল? স্টার্ট ভিডিও, জুম ইজ আনএবল টু ডিটেক্ট ক্যামেরা। দাঁড়ান, আমি আবার এইবার আসবো। ক্যামেরা আমি বন্ধ করে রাখছি। হ্যাঁ, অন্ধকার করে সবকিছু।
অনেক অলরেডি স্যার অনেকে জয়েন করে ফেলেছে আপনার
না, আসুক,
ক্লাসে।
7:30 বাজুক।
আচ্ছা আচ্ছা, আপনার মেসেঞ্জারে আমি লিংকটা দিয়ে দিয়েছি।
হ্যাঁ, আচ্ছা, মেসেঞ্জারে যাবো আবার এখান থেকে বেরোয়?
স্যার এখান থেকে বের হতে হবে না, আপনি হচ্ছে স্যার মেসেঞ্জারেই দেখতে পারবেন যে আপনি যে লাইভে চলে আসছেন।
আচ্ছা,
তারপর আপনার স্লাইড দেখা যাচ্ছে সবকিছু স্যার
গুড।
মেসেঞ্জারে। আপনি
ও,
একটু ভিডিওটা অন করলে প্রথম হচ্ছে স্যার আপনি অ্যাক্সেস মেডিকেল স্কুল গ্রুপে দেখতে পারবেন যে আমি।
হ্যাঁ, আমি ওই যে দেখতে পাচ্ছি লাইভ ক্লাস।
জি স্যার।
হ্যাঁ, ফাইন, দেখতে পাচ্ছি। ইয়েস, মোবাইলে দেখছি ওটা।
মোবাইলের যে ভিডিওটা আপনি স্যার এটা একটু মিউট করে দিলেন।
ও হ্যাঁ, রাইট রাইট, ইউ আর ঠিকই বলছেন, ভুলেই গেছিলাম।
ওকে
ক্যামেরাটা
স্যার।
অ্যাডজাস্ট করি আগে, ক্যামেরাটা অ্যাডজাস্ট করি, চেহারা তো দেখা যাবে। হুম, নাও ইটস ফাইন। আমরা ঠিক 4 মিনিট পরে 7:30-তে স্টার্ট করবো,
ইনশাআল্লাহ স্যার, ওই থ্যাংক ইউ
ইনশাল্লাহ।
স্যার, আপনি এমনিতেই স্টার্ট করে দিতে পারেন, অনেকেই স্যার জয়েন করে ফেলেছে।
ওকে, যাও 7:30 থেকে। Assalamu alaikum. Good evening. We meet again after a week, and we meet again for having some chit chat. And today we will have some discussions on one of my most favorite topics, and that is heart failure. Yes, we have a few discussions on the same topic in Axis Medical School by more expert people than me. So I hope you will find my lecture a bit boring after getting the knowledge from more experienced people in the lineage. So let's start with it. Today's topic is heart failure. So what is heart failure? In a simple term, heart failure means it is a condition when heart cannot pump adequately as per body requirements. So what is the basic pathophysiology of heart failure? What happens in heart failure? The first thing before going to the pathology, we must know what actually done by heart in normal conditions. In fact, heart is a pumping organ and it pumps blood into the circulation. The left side of the heart, it pumps into the systemic circulation, and the right side of the heart pumps into the pulmonary circulation. In other way, the left heart gets the blood from the pulmonary circulation and pumps it into the systemic circulation. Just opposite happens in the right side of the heart. The right side of the heart, or the right heart, it receives blood from the systemic circulation and pumps it into the pulmonary circulation. If we make it a more detail, then we can tell that the pulmonary veins deliver the blood into the left atrium. The left atrium then passes it to the left ventricle, and ultimately the left ventricle pumps the blood into the systemic arteries. In the right side, the systemic veins delivers the blood into the right atrium. The right atrium then passes it into the right ventricle, and the right ventricle ultimately pumps this blood into the pulmonary arteries. So we can say that the atria, right and left atria, are the receiving chambers of heart, and the ventricles are the pumping chambers of heart. So as heart failure occurs when heart is unable to pump, or in other words, we can say that pumping is the main function of heart. We can also say that heart failure actually implies failure of the ventricles. So when the ventricle fails to pump, be it right, be it left, be it both right and left, it occurs when the pumping force is weak or when there is high resistance to pump. It means when heart is not pumping well because the myocardium, which is the pumping station of the heart, is not strong enough to pump. Or it may also occur when myocardium is strong, but still the area to be pumped has much higher pressure. It actually gives much higher resistance, so the myocardium is unable to pump properly. So weak pumping force actually occurs in myocardial diseases like myocardial infarction, valvular regurgitation that leads to myocardial dilatation, cardiac chamber dilatation, myocarditis, and cardiomyopathies. And resistance to pump, it occurs in hypertension. That means for the left side of the heart, it is systemic hypertension or simply the hypertension. And the right side of the heart, it is pulmonary hypertension. It also occurs in aortovalvular stenosis. In the left side of the heart, it will be aortic stenosis. In the right side of the heart, it will be pulmonary stenosis. So what is the consequences? Now we are getting something into the pathophysiology of heart failure. So what actually happens when the heart, the ventricles are not pumping well? In one side, there is low cardiac output. So there will be poor tissue perfusion and there will be some sort of organ dysfunction. On the other side, there will be high pressure in the heart because as heart is not pumping well, there will be accumulation of blood in the heart chambers. So there will be high pressure in the cardiac chambers. So that will actually hamper the venous return. How? Because the veins actually drain into the atrium. So if the pressure in the atrium is high, then veins need more force to release the blood in the atrium. But veins themselves are not much contracting force to have. So what happens? There will be reduced venous return. And that leads to accumulation of blood in the venous system, which we call congestion. And when there is congestion, because of the backflow of pressure, there will be edema. In the left side of the heart, there will be pulmonary venous congestion and pulmonary edema. In the right side of the heart, there will be systemic venous congestion and systemic edema. So congestion is a very common thing that happens in heart failure. In fact, the edema, be it dependent edema, generalized body edema, or the pulmonary edema, this edema is the hallmark of heart failure. That is why heart failure is also named as congestive cardiac failure. Because edema originating from the congestion, heart failure is also called congestive cardiac failure. So these two terms are synonymous: heart failure, congestive cardiac failure. I have mentioned because uh, many of the senior teachers actually prefer the term congestive cardiac failure. So if you are not aware of this term and do not know that this is actually nothing but heart failure, you may get confused in the exam. So that is why I have mentioned the term congestive cardiac failure. Many literatures, in fact, heart failure term is not used, particularly the older literatures, they use the term congestive cardiac failure. And most of the senior teachers, senior examiners whom you may face in the exams, still prefer the term congestive heart failure. So what happens when there is low cardiac output? One consequence is low cardiac output. It will lead to activation of neurohormonal compensatory mechanisms. Three mechanisms are activated. One is renin angiotensin aldosterone system, another one is posterior pituitary, and another one is sympathetic nervous system. So what do they do? Actually, they are activated for the benefit of the body. So what does it do? Yes, if renin angiotensin system is activated, there will be production of more aldosterones. So aldosterone will cause salt retention that will increase the blood volume. So if blood volume is increased, the cardiac output will also be increased. ADH causes water retention in the kidneys, so it will also increase the blood volume. Consequently, cardiac output will also be increased. Adrenaline and noradrenaline, they actually increase the contractility of the heart. They act on the beta 1 receptor of the heart and increase the myocardial contraction. So it will also improve the cardiac output. So all these hormonal mechanisms that are activated in heart failure are intended to be beneficial because they all try to increase the cardiac output. I have already said that cardiac output is reduced in heart failure, and that causes tissue dysfunction, organ dysfunctions. So to overcome this tissue dysfunction, all these mechanisms are activated that in combination of their action, they actually increase the cardiac output. And they are activated because of the benefit of the entire body, benefit of the organs. But unfortunately, this is not the end of the story, because cardiac workload, that means the work that heart has to perform, depends on three factors. One is the myocardial contraction. So more there is contraction, more the heart have to work. One is the the quantity of blood to pump. And another one is the resistance to pump. So what is resistance to pump? It means that the cardiac workload actually depends on the quantity of blood, and the quantity of blood that is coming is nothing but the venous return. It is also termed in respect of heart failure as preload. So this is the load which heart has to take for pumping. And another one, that is the resistance, it is the blood pressure against which heart has to pump, is the afterload. It means that it is the load against which heart has to pump. So these three factors, that is myocardial contraction, preload, and afterload, these three determines how much the myocardium, the ventricles, the heart needs to work. Remember, in heart failure, the myocardium, the ventricles, the heart is already diseased. So if it has to work more, it will actually decline its function. A diseased organ should be given rest. But if it is forced to work more, its overall function, its overall performance is bound to decline in the long run. So what happens? If renin-angiotensin system and ADH are activated, they increase the salt and water retention respectively. That leads to increased blood volume, that increases venous return. That means it increases the preload. So it is increasing the load on the heart. Activation of the sympathetic nervous system and the renin-angiotensin aldosterone system causes two things. One is sympathetic system directly causes vasoconstriction by acting on the alpha receptors. And renin-angiotensin aldosterone system, apart from producing aldosterone, it also produces angiotensin 2. This angiotensin 2 is also a vasoconstrictor. So this angiotensin 2 and the catecholamines, adrenaline and noradrenaline, they cause vasoconstriction that causes increase in peripheral resistance. So there will be rise in blood pressure. That means rise in afterload. Again, the workload of heart is increased. The sympathetic nervous system, apart from causing vasoconstriction, it causes increased force of contraction and increased heart rate. So overall, it also increases the contraction of myocardium. So all these three mechanisms actually the neurohormonal mechanisms, although they have intended to benefit the body, they are actually increasing the cardiac workload. They are increasing the afterload, they are increasing the preload, and they are increasing the myocardial contraction. So they ultimately increase the workload of the diseased heart. So what happens? There is increase in cardiac workload in the diseased heart, and that will lead to decrease in cardiac function. So the neurohormonal activation, although they are intended to improve the tissue perfusion, that is the beneficial effect, ultimately leads to worsening of the heart failure. So yes, they are activated to save the body. Okay, they are trying to save the body, but on the contrary, at the same time, trying to do so, they are actually harming the diseased heart. Another thing I have to mention that although by definition, I have already said this is the simplest definition, when heart cannot maintain the cardiac output for the as per the demand of the body, it is heart failure. But in not all patients of heart failure, the cardiac output is reduced. In many patients of heart failure, the cardiac output is still normal, and they are called heart failure with preserved ejection fraction. Ejection fraction is the fraction of the end diastolic volume which is ejected through cardiac output. So when cardiac output is normal, the ejection fraction will also be normal. In this group of patients, the main abnormality is not the reduction of cardiac output, rather an increase in the pressure in the cardiac chambers. And this increase in pressure in the cardiac chambers is called elevated filling pressure. That is why the definition of heart failure is a bit modified, a bit complicated than the basic simple one. And that is, heart failure is a condition when heart cannot pump adequately as per body requirements or can pump adequately with elevated filling pressure. Okay, so the definition has got a bit difficult than the basic one, but still during Viva exams, if you mention only the first portion of the definition, heart failure is a condition when heart cannot pump adequately as per body requirements, it is still possible. It is still possible. So heart failure is classified as left ventricular failure and right ventricular failure, as well as acute heart failure and chronic heart failure. So the names themselves actually describes what happens in these different types of heart failures. Acute heart failure is a severe heart failure and that develops within a very short period of time. On the other hand, chronic heart failure is develops over a long period, over days, months, and weeks. Okay. So what happens in left ventricular failure? Just I want to describe the two failures, right and left heart failures separately, because these two are very, very much popular topic to be asked in the oral exams. So in left ventricular failure, blood accumulates in the left side of the heart. So there will be a high or elevated filling pressure in the left heart. So there will be reduced venous return from the pulmonary veins. There will be pulmonary venous congestion that ultimately will lead to pulmonary edema. So there is edema in the lungs, and this pulmonary edema will hamper the oxygenation of blood. That is why the main symptom of left heart failure is dyspnea, shortness of breath, respiratory difficulty. There are three typical characteristics of the shortness of breath in left ventricular failure. One is exertional dyspnea. This actually happens when the heart failure is new onset. In the initial days, in the early days, the dyspnea does not occur when the patient is at rest. It occurs only when the patient does some physical exertion. That is why it is called exertional dyspnea. But remember, it occurs only in the early days. Later, when the heart failure is more severe, the dyspnea persists all the day long, but still they are aggravated when the patient tries some exertional activities. That is why it is called exertional dyspnea. That is the dyspnea which is brought on by or aggravated by exertion. Another one is orthopnea. It means shortness of breath or dyspnea that occurs when the patient lies down. Finally, paroxysmal nocturnal dyspnea. It is a form of severe shortness of breath, very severe respiratory distress that happens when the patient sleeps at night. So it wakes the patient up from sleep, and patient jumps into the window to have some fresh air in the aim that the fresh air might help his breathing. So these three types of dyspnea actually characterizes the left ventricular failure: the exertional dyspnea, orthopnea, and paroxysmal nocturnal dyspnea. Signs, yes, there are three cardinal signs. These important. This one is extremely important because these are asked in the Viva board, and you are less likely to pass if you fail to answer this. This is a very important question in the MBBS final prop exam. What are the three cardinal signs of left ventricular failure? One is pulsus alternans, one is gallop rhythm, and one is bilateral basal crepitations. So what is pulsus alternans? It means there is alternating strong and weak pulses. One pulse will be strong, the next pulse will be weak, the next pulse will be strong. So there is alternating strong pulse and weak pulse. This is pulses alternance. Gallop rhythm means presence of the third heart sound. In normal conditions, only first and second heart sounds are audible, just as lub dub, lub dub, lub dub. But in gallop rhythm, there will be three heart sounds. The third heart sound will also be audible, and it bit sounds a bit like the sound of the running horse. That is why it is called gallop rhythm, just like this. And finally, bilateral basal crepitations. Basal crepitation means that the crepitations are audible more from the back of the lungs, from the back of the chest. The lung, because of the oblique fissure, the anterior part of the lung is actually the upper lobes, and the posterior aspect actually represent the lower lobes or the base. So that is why as pulmonary edema normally accumulates in the more dependent part of the lung, so the crepitations will be more prominent in the lower part or the bases of the lungs, and bases are audible more from the posterior side. That is why bilateral basal crepitations are audible when you auscultate the chest from the back. Fine. So what are the diseases that causes left heart failure? The most common cause of left heart failure is myocardial infarction. And then another very important and very common cause is hypertension. And number 3 is mitral or aortic valvular disease. So these 3 are the common causes. Even if you mention only these 3 in the prof in the exams, that's fair enough. Yes, the other 2 common causes, although not as common as these 3, are cardiomyopathy and myocarditis. They are relatively uncommon. So for exam purpose, you just have to mention myocardial infarction, hypertension, and aortic or mitral valvular disease. Now let's switch to the right ventricular failure. What happens? And actually the consequences is the mirror image of the left heart failure, but only the structures are different. Structures affected, the circulations are different. What happens? Because of the accumulation of blood in the right side of the heart, there will be elevated filling pressure in the right heart. So the systemic veins will find it difficult to release the blood in the right heart. So there will be systemic venous hypertension, and finally there will be systemic edema. The edema which is more prominent in the dependent part is called dependent edema. And they are also present in different organs of the body. Even they may present with pleural effusion or ascites, or may they present with edema over the sacrum in the lying down patient. In the upright position or sitting position, the edema is most prominent in the most dependent part, that is over the shins. So what will be the symptom? The symptom will be generalized body swelling, that is generalized edema, which is most prominent in the dependent parts. And then the most important question from right heart failure, that is the 3 cardinal signs of right heart failure. These are raised jugular venous pressure, tender hepatomegaly, and dependent edema. Jugular venous pressure rises naturally because the jugular veins cannot release the pressure, cannot release the blood into the right atrium because of the elevated filling pressure in the right side of the heart. So there will be accumulation of extra blood in the venous system, and that is seen in the jugular veins. That is why there is raised jugular venous pressure. Tender hepatomegaly, it occurs due to congestion of the systemic veins. Congestion means passive swelling of a part of the body or an organ due to reduced venous return. And tender hepatomegaly occurs due to reduced venous return from the liver. So there will be accumulation of more blood and fluid in the liver, and acute enlargement of the liver will lead to tenderness. That is why it is tender hepatomegaly. And obviously dependent edema I have already mentioned. So these 3 are the cardinal signs of right heart failure: raised jugular venous pressure, tender hepatomegaly, and dependent edema. So what are the causes of right heart failure? The most common cause is secondary to left heart failure. Usually most of the causes of left heart failure leads to pulmonary hypertension, that is a rise in the pressure of the pulmonary arteries, and that leads, so there is a increased resistance of the right heart to pump, so there will be right heart failure. And another condition, it is called cor pulmonale. So what is cor pulmonale? Cor pulmonale means right ventricular hypertrophy due to pulmonary hypertension, which is due to primary disease of the respiratory system. So there is a disease of the respiratory system that leads to pulmonary hypertension, and that leads to right ventricular hypertrophy. It's the same mechanism, increased workload, okay, increased resistance, I'm sorry. So what are the conditions commonly cause cor pulmonale? One is COPD, that is the majority, more than 90% of the right ventricular failure are secondary to COPD. Then interstitial lung diseases, and another condition where the pulmonary arterial pressure is persistently high uh, due to no cause. No cause is found behind the rise of pulmonary blood pressure. This is called idiopathic pulmonary hypertension. There is no left heart disease, there is no disease of the lung itself, but the pulmonary arterial pressure is high. This is IPH or idiopathic pulmonary hypertension. These three are common causes of cor pulmonale. So right ventricular failure can occur in secondary to left heart failure or secondary to respiratory system diseases like COPD. Yes, uh, like the left heart failure, the right-sided valvular disease may also cause right heart failure. The pulmonary valvular diseases, the tricuspid valvular diseases, they can produce, but the incidence of right-sided valvular diseases is extremely rare, so they better not to be mentioned in the exams. Another condition is biventricular failure. It means both right and left hearts, both right and left ventricles are not functioning well at the same time. At the onset of the right ventricular failure and the left ventricular failure occurs simultaneously. It differs from that what we thought, what we mentioned, right ventricular failure secondary to left ventricular failure. In that condition, there is also both the ventricles are not working well. But the fact is, the left heart started dysfunctioning first, followed by the right heart. But in biventricular failure, both start dysfunction at the same moment. That is why it is called biventricular failure, not to be confused with right ventricular failure, secondary to left ventricular failure. So biventricular means right ventricular failure and left ventricular failure beginning at the same time and occurring at the same time. The causes are severe anemia, thyrotoxicosis, cardiomyopathy, and myocarditis. Another term also exists that is called high output failure. I have already mentioned in heart failure, there is usually reduction in cardiac output. Thereafter, I mentioned in some cases there will be no reduction, there will be normal cardiac output, and we termed it heart failure with preserved ejection fraction. But now there is a condition when the cardiac output is more than normal. This is called high output failure. And this high output failure actually is not a problem in the heart itself. It occurs due to increased demand of the body. Okay. So because of the increased demand of the different tissues of the body, heart pumps more than that its capability, and it leads to increased uh, filling pressure, that also a component of heart failure. So high output failure, that means heart failure with increased cardiac output, occurs in severe anemia, thyrotoxicosis, in pregnancy. I have mentioned very here, but I will request you not to utter this term in the exam board because very is extremely rare nowadays. So what are the differential diagnoses of heart failure? In fact, heart failure patients presents with shortness of breath. So other common conditions which also present with shortness of breath should come as the differential diagnosis of heart failure. So I have put this differential diagnosis according to the age of the patients. because I think these differentials may help you to make the differential diagnosis if you get a heart failure case in your long case. If the patient is less than 50 years age, that is, we call them young patients, although 50 years, 48 years, 47 years, they are not much young, but still we term it young patients, that is, who are less than 50 years age. The main differentials will be bronchial asthma and psychogenic dyspnea. And those who are 50 or more, the differentials will be chronic obstructive pulmonary disease, COPD, bronchial asthma, and interstitial lung disease. So let's talk how can you distinguish these conditions from heart failure uh, at bedside without doing any investigations. First of all, let's talk about the differentials in the EM. So if you get a case of heart failure, then you have to distinguish it from bronchial asthma. So if you are asked why this is heart failure, you just have to tell that uh, this is heart failure because the patient is dyspneic and there are bilateral basal crepitations. This is good enough evidence to call it heart failure. And then if you are asked, then you why this is not bronchial asthma? So if you are asked such a question, you have to tell that this is not bronchial asthma because there is no diurnal or seasonal variation of symptoms. Because in asthma patients, the dyspnea increases at night. In fact, the dyspnea increases in particular seasons, particularly in the winter seasons. So in heart failure patients, there is no such variation. Number two, there is no vesicular breath sound with prolonged expiration, and there is no rhonchi. In asthma, we expect the breath sound to be vesicular with prolonged expiration, and there will be added sound like rhonchi. So why this is not psychogenic hyperventilation or psychogenic dyspnea? In psychogenic dyspnea, actually the breathing pattern is bizarre, and if you examine the chest, there should be no abnormal finding. So this is heart failure, and this is not psychogenic dyspnea because there are obvious abnormal findings, that is the crepitations in chest examination, and also the breathing pattern is not bizarre. That is why it is not psychogenic hyperventilation. If the patient is elderly and you have diagnosis heart failure as the provisional diagnosis, the first differential will be COPD. So why this is heart failure and why this is not COPD? If you are asked, then you have to say that this is not COPD because there is no vesicular breath sound with prolonged expiration and there is no rhonchi, just like bronchial asthma. Please don't start with the term there is no history of smoking, because smoking, yes, smoking is the most common predisposing factor behind COPD, but absence of smoking, although it excludes, virtually excludes COPD, but the presence of smoking does not exclude other disorders. Suppose a patient is asthmatic and he or she is a smoker. So you cannot tell, as because he is a smoker, this cannot be asthma, this is COPD. As because he is a smoker, this cannot be heart failure, this is COPD. So smoking is important in the diagnosis of COPD, but absence of smoking does not indicate other disorders. Or okay, why this is not bronchial asthma? It is not bronchial asthma because there is no childhood onset, there is no diurnal or seasonal variation of symptoms, and again there is no chest findings like vesicular breath sound with prolonged expiration, and there is no rhonchi. So why this is not interstitial lung disease? And this is actually a condition which mimics heart failure more closely. Why? Because these patients also present with dyspnea, and you will also have bilateral crepitations in these patients. So they are actually very difficult to differentiate from heart failure. But one point that clearly indicates heart failure is orthopnea. In heart failure, the dyspnea will increase when the patient lies down, but in interstitial lung disease, the dyspnea is not affected by the posture of the patient. So this is not interstitial lung disease, rather this is heart failure, because there is orthopnea and there is no suggestive occupational history, because very common cause of interstitial lung disease is occupational lung diseases like pneumoconiosis, poll workers, pneumoconiosis, asbestosis, silicosis. So there will be some occupational history of exposure to these things. And another one important cause is idiopathic pulmonary fibrosis, where you expect a clubbing. So as there is no suggestive occupational history and there is no clubbing and there is orthopnea, this is not interstitial lung disease, rather this is heart failure. So in this way, you have to combat the viva board, the long case, when you have a heart failure as your long case. Now, what complications develop in heart failure? The important complications are respiratory failure because of the pulmonary edema. It hampers the oxygenation. Then the cardiogenic shock. When the cardiac output is very low, there is the overall reduced tissue hypoperfusion leading to cardiogenic shock and cardiac arrhythmias. Acute kidney injury occurs and also electrolyte imbalance. So why this complication occurs? I tried to make some explanations of this. Respiratory failure occurs due to pulmonary edema. Cardiogenic shock occurs due to reduction of cardiac output. Acute kidney injury, this is a result of reduced renal perfusion. So this is a kind of pre-renal failure. And arrhythmias, this is multifactorial. There are different factors that can cause arrhythmia in a heart. One is sympathetic activation, then cardiac remodeling. It means ventricular enlargement or ventricular hypertrophy that occurs due to increased filling pressure. And also there is electrolyte imbalance like potassium hyperkalemia or hypokalemia that also makes the heart prone to arrhythmias. What are the arrhythmias in heart failure? The common arrhythmias are atrial fibrillation, ventricular tachycardia, and ventricular fibrillation. So what are the electrolyte imbalance in heart failure? In heart failure, hypokalemia, hyperkalemia, and hyponatremia, all these three can occur. Hypokalemia usually occurs due to activation of the renin-angiotensin-aldosterone system. That causes formation of aldosterone, which causes retention of sodium and removal of the potassium from the kidneys. So it leads to hypokalemia. Also, heart failure patients, we will discuss later, are treated with loop diuretics that also causes hypokalemia. Hyperkalemia occurs if there is acute kidney injury in heart failure. And also, many heart failure patients are treated with spironolactone, which is an aldosterone antagonist that leads to hyperkalemia. Hyponatremia occurs due to increased ADH secretion. So it retains more water. If the content of the body fluid has more water and normal sodium, then there will be dilutional hyponatremia. And again, loop diuretics used in heart failure can also cause hyponatremia. So let's go to the investigations of the heart failure. The four basic investigations are ECG, chest X-ray, echocardiogram, and serum brain natriuretic peptide or BNP. ECG is the first investigation to be done, as ECG is the most important investigation of any cardiac disorders. So it is done in heart failure. It must be done in heart failure. But the truth is, ECG is never diagnostic of heart failure. ECG cannot diagnose heart failure. But it has its own importance in the investigation of heart failure. Why? Because it can identify causes like myocardial infarction, and also it can detect arrhythmias. Arrhythmias are common complications of heart failure, already mentioned. So to detect the cause and to detect arrhythmias, we have to do ECG. The next investigation is X-ray chest. And in X-ray chest, there are certain findings that are suggestive of heart failure, just like enlargement of the cardiac shadow. Then upper lobe diversion of veins. It means normally the veins are more in number and size in the lower part of the lungs. But if the veins in the upper part of the lungs becomes equal or more in number or in size then the lower part veins, then it is called upper lobe diversion of veins. Then there are Curtis B lines. These are small, very small horizontal lines in the periphery of the lung fields. Oh. Okay. So I hope the connection is regained. Thank you. So there were a few technical errors. Sorry for the technical errors. So what we were there, this is the X-ray findings. That is, this is upper lobe diversion of veins. The upper lobe veins are prominent. This is actually a schematic diagram. This is not actual X-ray. These are small lines, Curtis B lines, and this is enlargement of the cardiac shadow. These are diffuse opacities. These actually occurs due to pulmonary edema. And finally, there are pleural effusions. So this is the ideal X-ray findings in heart failure. But in practical situations, we do not find all these scenarios. Actually, it looks like this. So there is enlargement of the cardiac shadow, and diffuse opacities in both sides. And these diffuse opacities are more prominent in the central region of the lung fields. So this is the practical X-ray of heart failure, and this is the ideal X-ray of heart failure. Practically, you will not get these findings. Common findings are enlargement of the cardiac shadow and diffuse opacities. Finally, the ejection fraction. That means the echocardiogram. In echocardiogram, the parameter that determines whether this is heart failure or not is the ejection fraction. It should be more than 50% or equal to 50% in normal person. If it is less than 50%, we call it heart failure. Echocardiogram is not important only for the definition or the diagnosis of heart failure, but also it helps in detection of the causes like ischemic heart disease, valvular heart disease, or cardiomyopathy. Serum BNP. This is a biomarker of heart failure. It raises in all forms of heart failure. So it is useful in those people who have heart failure, but still the ejection fraction is more than 50%. I have already said that there will be a group of people having we call heart failure with preserved ejection fraction. So if you find such a patient, you suspect clinically this is definitely heart failure, you do the echocardiogram, but unfortunately you found ejection fraction 50% or more. So still you can call it heart failure if you find serum BNP raised in these patients. So serum BNP is extremely helpful in diagnosis of heart failure with preserved ejection fraction when echocardiogram is not showing a low ejection fraction. Okay, now about the drug therapy in heart failure. We are almost at the end of the lecture. So before going to the drug therapy of heart failure, I want to recall that the main thing that will improve the cardiac function are anything that reduces the workload of the diseased heart, be it myocardial contraction, be it preload, be it afterload. So there are different groups of drugs: ACE inhibitors, angiotensin receptor blockers, loop diuretics, even beta blockers, aldosterone antagonists, nitrates, and cardiac glycosides used in heart failure. So let's just think 1 or 2 minutes to discuss about the mechanism of these drugs. ACE inhibitors, the most important drug to be used in heart failure. They inhibit the outcome of the renin-angiotensin system, so they reduce both preload and afterload. So in this way they reduce the cardiac workload. And the important members of this group are ramipril and perindopril. ARB, the angiotensin receptor blocker, they act in the same renin-angiotensin system, reducing the same preload and afterload and reducing the cardiac work. Important members are losartan and valsartan. Beta blocker. They inhibit the sympathetic nerve induced myocardial contractility. So they reduce the myocardial contraction and reduce the cardiac workload. The two beta blockers that are frequently used for heart failure are carvedilol and bisoprolol. Remember, we use selective beta 1 blockers, not the non-selective beta blockers. Aldosterone antagonist, they antagonize the effect of aldosterone produced as a consequence of activation of renin-angiotensin-aldosterone system. So they decrease the preload and decrease the cardiac workload. The aldosterone antagonist available in our country is spironolactone. Loop diuretics, they are used more than beta blockers, even more than the aldosterone antagonist, even in some places more than the ACE inhibitors. So popular drug for heart failure. They reduce the blood volume, so they reduce the hydrostatic pressure, and thus they reduce the pulmonary or systemic edema. The most common agent is furosemide. Nitrates, they are vasodilators. So they dilate the arteries. So dilating the arteries leads to reduction in peripheral resistance, reduction in afterload. They dilate the veins, so the veins can now accumulate more blood. So there will be reduction in venous return, there will be reduction in preload. So vasodilators can reduce both preload and afterload, so they can reduce the cardiac workload. The common vasodilator, nitrate vasodilator in use is glyceryl trinitrate. Finally, the cardiac glycosides. They increase the calcium ion concentration within the myocyte. They inhibit some sodium potassium channels, which again has indirect effect on the uh, calcium counter transporter. In this way, they can increase the intracytosolic calcium concentration in the myocytes. So increased calcium concentration leads to increased contraction. So it will help to increase the cardiac output. And the agent that is used as cardiac glycoside for heart failure is digoxin. But remember, By increasing the cardiac contraction, they will actually add some workload to the heart. So this is not a very good drug for heart failure, but they are still used in heart failure. How heart failure is treated? Heart failure patients are treated primarily by giving advice about the fluid and salt intake. There will be restriction of salt and water intake. We advise the patients not to take any added salt. That means the patient will take the normal salt that is given in other situations with other dietary components. So no added salt in the plate will be taken. And fluid restriction, it means that the patient should restrict the oral intake of water and other fluids to 500 ml plus previous day urinary out. The drugs that is used in heart failure are ACE inhibitors or angiotensin receptor blockers and loop diuretics. These two drugs are used most commonly. And when the heart failure is a bit improved, then we add beta blockers. Another important aspect of the treatment of heart failure is detection and treatment of complications. Because heart failure can lead to respiratory failure, cardiogenic shock, arrhythmias, acute kidney injury, electrolyte imbalance, and any of these 5 complications would prove fatal. So, apart from treating the heart failure patients, we must also look for the complications. Only treating the diseased heart does not save the patient. Other fatal complications must be looked for and should be managed accordingly. And finally, the identification of the cause of the heart failure and treatment of the cause if possible. Suppose this is a case of heart failure due to hypertension, then hypertension should be treated. If this is a case of heart failure due to acute myocardial infarction, then the patient should be treated in the coronary care unit for acute myocardial infarction. Just like this. If this is the case of heart failure due to valvular heart disease, then proper treatment, valve replacement or valve repair should be done. So this is very important also. There are some second line drugs. Apart from diuretics, ACE inhibitors, ARBs and beta blockers, there are some second line drugs which are used when heart failure is not controlled, is not improved with the use of the first line drugs. These are aldosterone antagonists, digoxin and nitrates. Finally, there are two special treatments that can be used in very advanced refractory cases. One is cardiac resynchronization therapy, another one is cardiac transplantations, but they are not readily available. Acute heart failure has its own importance in heart failure because acute heart failure is a medical emergency. So you have to know about something more regarding acute heart failure. It usually presents with sudden severe dyspnea, and apart from dyspnea, the patient may have cough and rarely the patient may have hemoptysis. The only finding that will make you think about acute heart failure in such a dyspneic patient is bilateral basal collapse. So what are the causes of acute heart failure? The most common cause of acute heart failure is acute myocardial infarction. Acute heart failure means the heart failure is developing within hours. It is so severe, the dyspnea is so severe that it brings the patient to the hospital within hours. So the cause of such severe heart failure developing within hours must be something dramatic. That is why acute heart failure is caused by some dramatic conditions like acute myocardial infarction, then hypertensive emergency. I have already said hypertension can cause left ventricular failure, but to produce acute heart failure, the hypertension must be very high, hypertensive emergency. It means systolic blood pressure more than or equal to 180 or diastolic blood pressure more than or equal to 110. This is called hypertensive crisis, and when it is associated with any target organ damage, it is called hypertensive emergency. Finally, any patient with chronic heart failure, if the patient stops the drugs abruptly, it may lead to acute heart failure. And development of any arrhythmia in a chronic heart failure patient who was otherwise reasonably well or suddenly a ventricular tachycardia develops, then the patient from chronic heart failure will turn into a case of acute heart failure. So these are the conditions which makes the heart failure very severe within minutes and brings the patient to the hospital within hours. So acute heart failure is a medical emergency. The patient must be treated after being admitted in the hospital. And preferably, the patient should be admitted in the coronary care unit. The first thing to be done is putting the patient in propped up position and starting high flow oxygen. In acute heart failure, it is invariably the patient has respiratory failure. So the high flow oxygen is essential in the management of acute heart failure. Then the patient should be given intravenous furosemide, and the patient should also be given intravenous dopamine if there is cardiogenic shock. So not all acute heart failure patients will have cardiogenic shock. So if the patient has cardiogenic shock, in addition to these three, propped up position, high flow oxygen, and intravenous furosemide, you have to add intravenous dopamine to maintain the blood pressure. And one thing you must not forget, that is, you should do an ECG and troponin I to exclude acute myocardial infarction, as this is the most common cause of acute heart failure. And there is a term, painless myocardial infarction. So we have to make sure that there is no myocardial infarction in acute heart failure. We have to detect any myocardial infarction in acute heart failure. And because acute myocardial infarction needs extra immediate management apart from the management of heart failure. So I think we have come to the end of today's discussion. We were a bit in a hurry today, but before ending, I just want to discuss a question in the professional examination. In professional examinations, it is better to write less to complete the answer sheet. So let's discuss the question. A 55-year-old gentleman was brought to the emergency with severe respiratory distress. Examination reveals bilateral basal crepitations. So what is the most likely diagnosis? And the second part is most critical, that is, make a checklist of clinical information to find out the cause of this condition. Just remember, they didn't want to the diagnosis is obviously it is left ventricular failure, that means dyspnea with bilateral basal cramps. Diagnosis is left ventricular failure. So the clinical information means the points in history and clinical examination, and that will help you finding the cause. So if you write the cardinal signs of left heart failure like bilateral basal cramps, pulsus alternans, gallop rhythm, these are useless in this answer because they have already said this is left heart failure, but they don't want you to establish left heart failure. They just want you to find out the cause from history and clinical examination. So for this answer, you first have to consider what could be the cause of this condition. The most important cause of these conditions are myocardial infarction, hypertension, mitral aortic valvular disease, and myocarditis. So you first have to write these are the more important causes of this condition. And then you make a table with both history and examination findings expected in these four conditions. That will reduce your writing time, that will put all the important information in the answer script, and that is always also a near complete answer. So writing more does not imply getting good marks. Writing the correct thing and writing the correct thing concisely attracts the examiner more. So for acute MI, there will be history of sudden severe chest pain, precordial pain associated with sweating and vomiting. In hypertension, if the cause is hypertension, then you may find history of hypertension. You may find very high blood pressure while examining the patient, or you may find the hypertensive retinopathic changes while doing fundoscopic examination, ophthalmoscopic examination. If this is a heart failure due to valvular heart disease, then there will be history of arthritis suggestive of rheumatic fever in childhood, past history of arthritis, and you may find the thrills and murmurs in the precordia. If it is a case of myocarditis, we know that most of the myocarditis cases are viral myocarditis, so there will be history of fever during this dyslexia episode. So in this way, this is not the prototype. This is even, I don't want you to copy this answer and write it in the exam. This is the way that you can answer such questions. So write the correct thing, write it concisely. I hope you will be benefited. Writing more pages after pages does not help in the exam. So thank you very much for staying so long with such a boring guy, and I hope we'll meet soon again. And till then, keep smiling. Thank you and Allah Hafiz.